Good evening, everybody. In lieu of doing our Zoom event tonight, we decided to do this as a Facebook Live. So feel free, if you're seeing this, to throw a comment up there, and we'll do our best to try to navigate the comments a little bit. And admittedly, I don't wear glasses yet, but I probably should be. And so I may not be able to catch everything, but we're going to do our best to navigate this. So hopefully this is going to be a lot of fun for everybody. This is what we're going to start doing on a routine basis, called Family Council. The idea behind Family Council is to create a platform for just strong, authentic conversation between us, between the family members, between our folks that come in here and provide services for us. And so tonight, we're really privileged to have Morgan Young with At Home Care and Hospice with us. She's been doing long-term care in the Tri-Cities and surrounding areas for quite some time, and just a wealth of knowledge and experience, and a great mom. She's doing doing a lot of schoolwork and just working really hard to continue to make an impact on our community. So I can't say enough good about Morgan, but Morgan, I'm going to turn it over to you, and take it away.
All right. Well, thank you so much for that introduction, Tim. Yes, my name is Morgan Young. I am a registered nurse. I have been working in the community for about the past 15 years. Been a registered nurse for 10 of those. My background is in geriatric care, so well, what that means is that I care for the aging community. I am in school, like he said, continuing my education and setting goals for myself as well. But tonight we are going to just kind of touch base on identifying things in our aging community that we can identify, and things that we can educate on, and what to do when those situations arise. So we want to talk about our elderly community. As we age, there's certain categories of ourselves that that we can start to see changes in. One of those obviously being changes physically. So as we age, one of the most common things is decreased muscle tone. So we are more prone to things like falls with injury. With the decreased muscle tone, there also comes decreased coordination, and also skin elasticity, which can cause wounds. So we want to provide a safe environment for our loved ones, and we want to identify anything that might contribute to falls. So we can just start the conversation off with that, because I know that's a super important thing that sometimes even preventable.
I think it's a great place to start.
Yeah.
Looking at that environment, looking at potential of falls, sources of falls. Not just physically, but there's a lot of other factors in there. So, and I also wanted to say, before we get too far in here, I also want to thank Laura Crocker, who is our the lead of our activities department. She's here in the background, and in fact, you might want to pull Facebook up there so you can actually see comments if there are questions, and you might be able to flag us with them, because it'll be a little easier for you to see. So, more support here. And like I said, for you guys, this is just really a platform for folks to be able to offer their thoughts, your feedback, your questions, those kinds of things. If you have ideas for topics for future family councils, let us know. But so let's talk about falls.
Okay, well, I guess the first place to start is what are some things that will put your loved one at risk for falls? The first thing is going to be something that may not be manageable, but what we call polypharmacy. So a lot of our elderly aging population, our individuals have lots of medicines they're on, 5 or more usually. And sometimes those medicines individually or together can contribute to things like dizziness and weakness and sleepiness, and those things can contribute to somebody potentially having a fall. The other thing is, like I said, the muscle weakness, and a lot of things can actually contribute to that. Age in general contributes to muscle weakness, as our muscles aren't as conditioned as they are in our younger years. And that leads to something that we actually call deconditioning. Deconditioning happens for a lot of different reasons, but one of the more popular, or more not popular, but one of the more common reasons is after hospitalization, let's say, or after just maybe an acute illness. If your loved one has been laying in bed for maybe 2 or 3 days, their body starts to adapt to want to be in the bed, to not want to be able to not get up. So the weakness that happens after that, usually just some good old-fashioned exercises can really help bring that person back to their prior level of functioning. We usually suggest something like physical therapy or occupational therapy. Even after like an acute hospitalization, the physical therapy may not even bring somebody back to their full level of functioning prior to that illness or injury, but we try to get it as close as possible. There may be a new norm of 80% or 90% towards that prior level of functioning, but that's still good and still enough to prevent falls in the future. The other thing that we look for is just things in the environment. If you start to notice some clutter happening, area rugs, the furniture that's in the middle of the room, things like that, those can all contribute to falls. Another thing that we tend to not think about is sight and hearing that can diminish over when we get to a certain age. So following up and making sure that our senses, our eyesight and our hearing are functioning, or getting some assistive devices like glasses or hearing aids, that can actually contribute to decreasing falls, your risk of falls. So what happens if you do get a fall then? Hopefully it's without injury. Sometimes there is injury. So then the most important thing is to treat any kind of acute injury, the skin break, maybe a skin tear, with clean bandages. But then afterwards, if it's a resident here at Petersburg Home for Ladies, then, maybe if you bring to the attention of the nursing staff, and they would be happy to bring in a physical therapist or occupational therapist to try to get that person, your loved one, back to their prior level of functioning.
So let's just ask that question real quick. How would you define what is physical therapy? What is occupational therapy?
Sure. So the easiest way to describe it, although not completely correct, is physical therapy works from the waist down and occupational therapy from the waist up. It's the simplest way to define. Physical therapy is going to work on getting you stronger in things like in walking, standing, pivoting, and that nature. And they'll also do assessments for if you need assistance with getting a walker or a cane or something of that nature. And they'll make recommendations based on what the actual need is, what they're identifying as the need. And then they'll show you some exercises, strengthening exercises. Occupational therapy, on the other hand, tends to work with more of the fine motor skills. So let's say that one of the ladies might, be having a hard time holding utensils, eating utensils. It could be from something as simple as arthritis, but there are adaptive equipments out there to make life easier. So it's almost as if, think of occupational as things that people do in their activities of daily living. Things like dressing themselves, things like feeding themselves, and toileting, things of that nature.
Right. And so how would that process start? If somebody was in need of those types of services, where does that pathway begin?
Oh, sure. Really just identifying. So if you as a loved one of somebody here at Petersburg Home for Ladies, would like to initiate their services, then you would, just talk to the registered nurses here, one of the nurses here, and or contact, through the doctor. The doctor would write an order, and they would set you up with services, and they would begin shortly after. So, and usually those services are short term. They last, maybe a couple of weeks to a couple of months, just depending on what the need is and what the goal at the end of the therapy is. And we will get your loved one as close to that goal as possible.
And I'll tell you that a program that we have here at the Ladies Home, we have Gio Mosconi as our strength trainer, and he works with our activities department, and he also will piggyback off of those programs. So what's kind of special is that should folks be coming out of physical therapy or occupational therapy services and potentially have graduated out of the program, like they've made the goals that the therapists have expected them to do, and so they're no longer part of the therapy program, that's where our team can come in and continue those services outside of qualifying for Medicare to cover that process. So just really good stuff. A lot of simple things that people can do every day to prevent falls.
And then after the therapists teach those activities, then even after the services end, your loved one can still continue to work with those tools that we have given them to continue to get stronger.
Yep.
And I mean, that's just one thing that you might notice as your loved one is getting older, is just some generalized weakness, and that does happen as we get older, especially after, like I mentioned, a hospitalization or any kind of injury or trauma. And when I say trauma, I mean a physical injury or potentially also an infection. We also call infection trauma because it's something that has jarred the body. So things like pneumonia, things like a urinary tract infection, these are all pretty common things. And that would require some therapy afterwards to get your loved one back to that higher level of functioning. Yeah.
And that's a great point, that even an infection can be considered a qualifying event for therapy. So, really important takeaway right there.
Yeah, absolutely. And then, I mean, we can probably make an entire talk about physical things that you would notice on your, in your loved one. Just to touch on a few, your body tends to slow down as the aging process continues. So you might notice things like a decreased appetite, decrease in the GI tract. You might notice decreased thirst and decreased urinary output, and those are all things that are pretty common. You might even notice, skin being fragile, and when I say fragile, not so much that, with the wrinkles, but because the elasticity, may be gone, and also because of the hydration in the skin, they're more prone to getting wounds, just little nicks on the skin, and it might be harder for them to heal as well. So, if you start to notice, the important thing really is that if you notice something going on with your loved one, is to say something. If you notice that there's a little nick on her skin, then we want to make sure that we can heal it properly. Or if you start to notice someone getting weaker and might benefit from therapy, then just mention it. And I'm sure that we'll make every effort to take care of those things that happen with our ladies.
And then, the important takeaway here is that there's a team of people involved in this process. There's a lot of eyes on every one of our residents, and so if there's something that's noticed, it's it may be something that's noticed by someone in dietary as opposed to one of our certified nursing assistants or something to that degree. So there's a team of people that are all constantly making observations.
Right.
So feedback on observations is a totally safe conversation to have.
Oh, absolutely.
And that's like really an important thing. So you guys as family members, as loved ones of our residents, that feedback from you guys to our nursing team, all critical in the total wellness.
Yeah. And as you identify things like the title of this conversation is identifying things that may happen and what to do about them and how you can assist. So so one of the most important things is just that good communication. Absolutely. We can also move on a little bit to what happens with our cognitive abilities as we age. This is a very important topic and a topic that I have that comes up pretty often is your loved one is entering their older years and they're having some forgetfulness. Well, what is common, what is normal forgetfulness in the normal part of aging, and what is crossing that line to, should I be concerned that this is getting towards dementia? I will say that dementia is not a common part of aging. Normal forgetfulness that happens where you walk into a room and you kind of forget why you're there, or misplacing your keys, or I don't know, forgetting what you had for dinner last Wednesday. You know, those are all normal, you know, part of cognitive decline as we age. Where the line gets crossed towards dementia is forgetting what you had for breakfast that morning. If you notice that your loved one is constantly repeating questions, you know, asking you a question, you answering, and then 5 minutes later they're asking you again and you're answering, and you know, then they forget that they asked you 5 minutes later. That's not a normal event. So that would be something to, you know, to bring up and say, you know, maybe we should, you know, have the doctor evaluate. Another part would be forgetting to, or not being able to care for themselves as they once did. So a normal part of aging is saying, you know, I don't feel like taking a bath every day. You know, I don't feel like I need it. I didn't do a whole lot. And, you know, I'm going to take a bath 5 days out of the week, and I'm completely okay with that. Or I'm going to wear the same clothes that I wore yesterday. I'm completely okay with that. That's kind of a normal part of aging. Refusing to perform hygiene care for themselves, or the inability to perform that task, that's not a normal part of aging. So that's something that you can identify and say, you know, maybe that means a qualification for an evaluation.
I was wondering if we could just back up a little bit and let's define dementia as a concept.
Sure. So dementia is essentially, for lack of better, it's a part of your brain that really just is not functioning. It's a decline in cognitive ability, and it's almost as if a portion of your brain is broken. The Alzheimer's Association, does some really great talks on the definition of dementia, but basically it is, there's different kinds of dementia. The most common kind is Alzheimer's, although sometimes you'll just hear the term generalized dementia. So under generalized dementia, you have the Alzheimer's, which is, like I said, the bigger portion of it. But then you'll also have vascular dementia, Lewy body dementia, Parkinson's dementia. There's lots of different kinds underneath that umbrella. So think of dementia as an umbrella term. If your loved one is living with dementia and they don't have a specific diagnosis, most likely it is Alzheimer's. The only way to really define what kind it is through different diagnostic tests, CTs and MRIs and such. And sometimes people forgo those tests because the doctors are pretty sure that it's generalized dementia, which is Alzheimer's. Yeah. So, and each kind of affects a different part of your brain too. So, a different area of your brain, depending on what area of your brain is affected, will determine, the behavior differences or the cognitive differences that you'll see that the loved one will exhibit.
So, what kind of recommendations could you make for us? So, somebody is over, a short period of time observing what they feel could be dementia behaviors in their loved one. What is the next step for that family member?
Sure. So occupational therapy is actually really great. They'll give tools to help give activities to the brain, for lack of a better vocabulary. Things like planning and making the same routine every single day. That really helps to slow any kind of progression. Things like learning new skills, because people are able to learn new skills even in early stages of dementia. So, maybe learning how to, play a new game, a new card game. Probably not something too intricate, but, simple. Go fish or something, that maybe they didn't know before. Spending time with loved ones, with familiar faces and family. But the occupational therapists, they use certain tools, they're not really diagnostic tools because the doctor uses diagnostic tools, but we can use certain assessment tools to find out what the cognitive functioning level is and the memory level is. And then we can present those tools to the physician, and that can help make a determination and help make a diagnosis. And there are medicines out there that treat and slow progression. So early intervention is key.
So again, just a team of people having a good conversation, asking good questions, and all questions seem fair. So, you know.
So if you are living with someone, or your loved one is experiencing dementia, maybe a new diagnosis, maybe an older diagnosis, or maybe you're starting to see some of the identifying markers that that you're concerned about. Yeah, absolutely. Just bringing that up to someone here at Petersburg Home for Ladies, and they can point you absolutely in the right direction.
Yeah. So what are some other conditions that we may see, changes that we may see in our loved ones, and so that's kind of the whole theme of tonight's topic is identifying the changing needs, and then connecting to that support system. Sure. So we've talked about falls, we've talked about some of the mental declines.
Yeah. So there's a whole other category of mental health, really that we have really started to focus more on in the past couple of years. People feeling, starting to feel the blues sometimes, especially in the winter months, and social involvement is so important. So I know they have great activities. Encouraging your loved ones to participate and to be social can really help. But if it is something that you're concerned about, if somebody they're noticing that they're feeling blue or anxious most days out of the week, then yeah, absolutely. There are other interventions that we can do. But one of the most important is to be surrounded by by other people.
Yeah.
Absolutely.
I think that's well said. People are designed to be in relationship with each other. I mean, that's just the nature of it. And, we're inspired by each other, we're challenged by each other, encouraged by each other, and so yeah, that socialization and group concept, it's so wonderful. And admittedly, that's been a challenge for a lot of folks. Like Morgan mentioned, we've been learning a lot about the impact of isolation on mental health over the last, say, 2.5 years. Where we've sort of been in and out of this window of opportunity to have group activities, to not have group activities, to have group dining, to not have group dining, and how that's all impactful on everybody. How often could you guys come to visit, and those sorts of things. So that roller coaster has definitely meant a lot, and so we encourage you guys to continue those conversations with us. Give us feedback on what our residents telling you guys, and how are they feeling things are going. Ask those questions. Get good feedback from them. Keep the circle of communication going.
And again, whether what you're observing is a physical, or whether it is cognitive, or whether it is emotional or mental health in nature, there is a plan that we can put into place. We can identify and make goals and put a plan in place with different members of the team to make sure that your loved one is cared for, in the best way possible.
Yeah, and every interaction is kind of like a snapshot, right? So if we have 1,000 Polaroids and we put them all side by side, now we have this spectrum of information about an individual, and so you may have that one kind of missing piece between the other pieces that we need to fill in the puzzle. So it's really good to have these kind of conversations. And that's what we're hoping to get back to doing, this sort of discussion environment in person, to be able to facilitate the back and forth conversation, and to provide you guys with topics and feedback that you're interested in learning about, and again, get that full spectrum of observation and teamwork going for these wonderful people that we all love.
Yeah, absolutely. Are there any questions that popped up?
Didn't look like anything showed up in the chat.
Okay. Yeah, because as we continue to do this, your questions are always welcome to myself as a visiting person here at Petersburg Home for Ladies, and I am honored to have been invited to just share information. I'll really just talk to anybody who will listen, honestly, about our aging community. That's my passion, that's my love. And currently I actually work with home health and in hospice services. So I have a pretty good idea of where people are in their journey and what services are a better fit. And as I meet new people and talk to new people, and if anybody has questions, I'm happy to answer. But as as questions come up as you ask, I'll be able to hopefully point you in the right direction for what services are a best fit for you.
So you just mentioned what could be considered a very intimidating transition would be the transition to hospice, and some people may have some apprehension about that or questions about that. Maybe you can touch on that for a little bit.
Yeah. So every person is different, and every situation is different. Every person and their healthcare needs, and their families, and their backgrounds, and their beliefs. So you have to meet you all where you are, and the word hospice can be intimidating, like you said. It can be a very scary word. It is end of life services. So if your loved one is, let's say, later on in the dementia process, or is suffering from a disease process that is not curable and they're not seeking treatment, something like COPD, CHF, cancer diagnoses, things that are going to continue to get worse, hopefully slowly. And what hospice does is it focuses on supportive services for your loved one and for family. It focuses on quality of life instead of diagnostic treatments. It's more of symptom management, and it in no way tries to take away from quantity of life, but it's just it does its best to add quality of life. So that's a service that we offer, that hospice companies in the area do offer. So if anybody's more interested in that, I'm happy to talk to them individually.
And I think it's beautiful that you mentioned that it's not a service that's just for the resident. There's an extension of that network of service to the family.
Absolutely.
And oftentimes that service to the family can last beyond the actual person who was receiving that initial care.
Oh yeah, absolutely. We offer bereavement services for many months after. We just want to make sure that we're there through each person's journey, whatever that may be and wherever that may take them. But like I said, every situation is very different. So we tailor make the care and set the care goals based on each different person's needs and journey.
Yep, and so, we've been talking about the changing needs in the residents, and admittedly, there's also changing needs in you guys. It's the loved one caregivers. So, these authentic conversations that we can have, more opportunity that we can have to interact with you guys and share, and particularly in a platform of a group environment, because your question may trigger a thought from somebody else, and we kind of grow as a team and grow as a community. So we're going to kind of continue to pursue this concept of family council, continue to offer these really authentic conversations, and we continue to welcome you guys' feedback. So.
Well, thank you so much for having me. It was a pleasure, and I'm happy to talk to anybody who will listen, but I'm happy to talk to anybody that wants to reach out. Tim has my information if any of you desire to reach out to me.
Yeah, and so Morgan, thank you, and thank you for what you do for our community. We want to thank all of our home health groups and various community partners that are out there. Thank you guys for all that you guys do. And Morgan, thanks for being with us tonight.
Thank you.
Okay, and thank you to our families.